Good evening. I'm Pittsburgh City Councilman Daniel Lavelle,
And I'm Councilman Reverend Ricky Burgess.
and we welcome you to Black Pittsburgh Matters. Black Pittsburgh Matters is a series of virtual town hall meetings affirming a citywide agenda that Black Pittsburgh does indeed matter. Black Pittsburgh Matters means that Black lives matter. We must protect the health and safety of Black people. It means that Black communities matter. We must focus on rebuilding and investing in Black communities. And it means that Black wealth matters. We must focus on increasing Black employment and entrepreneurship.
The Black community has been disproportionately affected by concurrent crises, the COVID-19 pandemic and its resulting economic crisis, and race relations, which are both public health crises. Normally, in times of crisis and great change, we'd be coming to you as the Black elected officials of Pittsburgh, having meetings across the city with our constituents, partners, and allies. Since we cannot do so safely in the current pandemic, we're now using this media and platform to come to you in the ways in which we can to talk about what we're doing, discuss policy and legislation concerning Black Pittsburgh. These meetings will be available via Facebook, YouTube, and the city's cable channel. You can contact or ask questions via the Black Pittsburgh Matters Facebook page or email us at blackpghmatters, that's blackpghmatters@gmail.com, and you can ask questions through our live feed right now. Today's town hall meeting topic is the city's vaccination campaign, vaccine and vaccination campaign.
And obviously, we're here to talk about the vaccination campaign because COVID has exacerbated Black health disparities and poor health outcomes in the Black community. It is not only important to deal with COVID's effect on Black communities, but also the underlying health problems and comorbidities that have made the pandemic so devastating for our community.
So in terms of my community, the East End, we're slowly coming out of it. My own church, we're looking to come back to church sometime this summer. But still, I still see a lot of fear. What are you seeing out there, Daniel, for you, your family, and your constituents?
So it's been interesting. A good amount of people have gotten vaccinated. Once we made it available, people said, yes, we want to. However, there are still those who are hesitant to get vaccinated. We do see people coming back outside, traversing. I had a call today where a law firm downtown, it was the first time that they had opened up since they shut down a little over a year ago. My wife actually, for the first time, had to go into the office this week on Monday. And that was the first time she'd been back to work in 14 months. And she told me that there were very few people there. There was almost no one to talk to because for the most part, people are still working from home and managing.
Well, the kids will be back, or some of the kids are back to school. Some of them will be back to school soon. And so I think we're slowly but surely getting ourselves together. Unfortunately, in the Black community, when we come back together, it won't be the way we left it, right? Because we know disproportionately the COVID virus has affected Black people, it's shut Black businesses, it's devastated our residents disproportionately. And so as the city works to ensure our communities get the resources they needed to come out this side of the pandemic, we also know that the solutions cannot be limited to just tackling COVID. We must address the health disparity, all the health disparities that Black communities face as well. We are honored today to be joined by our guests, Lauren Degrowski, a Critical Communities Manager for the City of Pittsburgh, Dr. Jerome Gloucester, who is the charge CEO of Primary Care, and Yvonne Uzain, founder and president of Me Productions. Welcome to this evening's town hall.
Thank you.
Thank you all for joining us. So, Dr. Gloucester, maybe we can start with you. You've been on the ground this entire time dealing with this. How have you seen our community respond? Early on, we had conversations encouraging people to get vaccinated, talking about the importance of it, because we knew that there was hesitancy. I'm just curious how you've seen our community respond to the vaccination.
Well, I think thankfully, as you mentioned, Councilman Lavelle and likewise Reverend Burgess, thank you for the opportunity to join tonight. We saw a big uptick in acceptance once the vaccine was available. I think that was through a lot of efforts, pre-work efforts of town halls and meetings and addressing concerns, addressing fears, addressing the past, addressing the present concerns around the healthcare system. And so, first of all, when phase 1 and 1A came out in our elderly, I was proud to see our elderly just turn out in droves and in mass that they wanted a vaccine. And I think a lot of us attribute that as well, is that a lot of our elderly have lived through polio and other things, and they saw what vaccines did to eradicate these diseases, and our community responded strongly. And as you also mentioned, initially the biggest problem was lack of supply. And now what's changed is there's lots more supply, and we've gotten a lot of people vaccinated, as you mentioned. But those who haven't been vaccinated, our younger population, especially, and I don't necessarily mean just our teens, but into the 20s and 30s, if you will. I think there's still some hesitancy there, and it's a combined sort of response or varied response. Some are hesitant because of still with concerns about the vaccine, but there's a lot of other hesitancy that's around just simply people feeling like they don't need it. They're convinced that they'll be all right now, that this is going to affect others more than themselves, and whether it's elderly or those who have really serious medical conditions. And if a person feels like they're healthy, they feel like I wear a mask and I either won't get it, or if I do get it, I think I'll be all right and I don't have to take a chance on this vaccine. And we're trying to get the word out that this is number one. When you're weighing your options of getting COVID and the likelihood of a problem from COVID compared to the vaccine, there's much higher chance of you either dying or having serious problems or long-term problems like long hauler disease from COVID rather than getting a vaccine. And then secondly, the big message that I'm pushing is let's protect our community, because maybe you as a young person would be fine, but there might be someone else who has a chronic condition or is older that you end up passing it on to, and they have a bad outcome. So let's do what's right for the health of our entire community.
Mr. Zhang, if you would tell us a little bit about your organization and the work that you do, and then we'll talk maybe specifically about the campaign, the city's campaign, but tell us a little bit about your background, and we welcome, I know you're not new to Pittsburgh, but certainly we welcome your firm and their participation in this effort.
Well, thanks, Councilman. So my name, again, is Ivan Juzang. I'm the founder and president of Me Productions. Me Productions is a behavioral health communications firm. So for the last 30 years, we've actually been exclusively working on health disparities, particularly in low-income urban communities of color around the nation. And so when we talk about disparities, obviously COVID is one that's impacted our community, but we're talking about everything from what I call youth violence, substance abuse, sexual reproductive health issues, chronic diseases, and then a list of health disparities on the mental health side. That's not even talking about economic, educational, and other social disparities. This is all just within public and mental health. So my company develops interventions because our position is very clearly that low-income communities of color aren't making bad decisions. That's what the media wants us to think that they're doing. They're making uninformed decisions. They have to get information in a culturally relevant way that enables them to make informed health choices. And so my company develops campaigns to do just that.
Okay, do you want to now tell us a little bit about the cities, the counties, actually, the county's campaign?
Yes. So happy to announce that on April 1st, we launched United Against COVID. This is a campaign sponsored by Allegheny County Health Department and Allegheny County Department of Human Services. The name of the campaign, as I said, is United Against COVID. The slogan for the campaign, which is really the main message we're trying to get out there, is spreading truth, not COVID. The campaign website is truthnotcovid.org, and all of the social media handles are at truthnotcovid. And even though we have a campaign that is based on good digital technology, we have a great YouTube channel, social media, the key thing that we think is going to make this campaign successful in Philadelphia and the county is the fact that we're focusing on mobilizing, educating, and training community leaders to be the primary message senders for the campaign. So as much as we want to, use technology and media, we find that the best way to deal with mistrust, the best way to deal with suspicion, the best way to deal with past mistreatment is to mobilize community-based organizations and community leaders to be the primary conduit for the campaign's messages. So we're excited to announce that the key part of the campaign is that we'll be training hundreds of community leaders across the city, across the county, to be messengers within their own neighborhoods, within their own communities, to spread truth, not COVID.
So how does that happen? If someone watching or a community member wants to become trained and wants to participate in the campaign, how do they go about doing so?
They just go to truthnotcovid.org and they'll see one of the main thumbnails or icons saying Me Training Portal that will send them down that process to be registered first. Then we do an organizational assessment on them so we kind of get a sense of their reach and impact. Then we ask them to watch the key educational videos that were developed with Black and brown doctors throughout the county, including Dr. Gloucester and some of his staff, where we're actually educating them on the truths, not only around the vaccine, but on testing. We're educating them on prevention and safety strategies. I mean, there's a lot of things that we should be able to learn beyond just getting the vaccine that can help our communities deal with health disparities. There's a lot of prevention messages, period, in this. And so they go through this process of watching these videos, and then we train them on how to use a digital toolkit so that they can customize and put messages in their own language, their own vernacular, their own idiom, so that it has their own flavor, so that they can talk to their neighbors and constituents at the community level.
Well, we are grateful with council and the mayor. As you know, the council has set aside a $100,000 grant that will go to a partnership between your organization and primary care to provide many grants to organizations and individuals who actually get the training. And so we are in the midst of working on how to do that. In fact, the person who is going to be leading that is Laura. And Laura, I want to talk to you a little bit. This idea, and this is something you brought to, at least to my understanding, even before the campaign, about this whole idea of trusted community leaders participating in maintaining or establishing health in the Black community. Can you talk about that a little bit, Laura?
Absolutely, and thank you, Councilmember Lavelle and Reverend Burgess. What really we heard from our community experts, who are our community members, is that a lot of the investment in infrastructure has been put into systems, whether that's health systems or public safety systems or social service systems, and we've in that way disinvested in neighbors, in community members, and in building trust among those neighbors. So the people who you trust in your own sphere might not be a doctor or a nurse or a social worker. It might be your mother or your grandmother or a friend down the street. And over time, over many generations, even we've disinvested in those relationships and sent people to systems. And what we've heard loudly and clearly from our community members is, when someone's in trouble, they'll call me. I live on the block. They know me. They trust me, but I don't know what to tell them. Some of our systems are really inaccessible. They're really difficult to navigate. It doesn't mean they're not doing great things, but if you're not an expert in navigating those systems, how are you going to, in a person's time of need, help them and shepherd them through that as well? And so we initiated a planning period of what we call the Neighborhood Health and Safety Academy. And our goal is to first plan that with the community, to understand what kind of questions people have about how to get support, how to get help. And then to stipend and train those individuals to participate in the academy, so that when someone has a need, they know who to call. They can call their neighbor, they can call a friend. We don't wait until something is escalated to the point where they're calling 911. So we're trying to remove some of this reliance or calling to 911 to a public health focused approach, a preventative approach. We get it early because people who are trusted get it. And, this is the spirit of the Me campaign. It's rather than putting all of this investment into institutions, we put investment into people because we know who we trust. Even if we are people who don't have confidence in systems that we want to help us, we do have confidence in our neighborhood leaders. We do have confidence in our neighbors. And so with the work that we're really excited to do, thank you to, council, to both of you, to council and to the mayor, is to help to stipend community members to engage in this learning experience and then to be advocates to their neighbors. And the second piece of that is to make the vaccine accessible. We have a partnership with Allegheny Health Network with their street outreach and co-responder program. And what we found from their information they've shared with us is if the vaccine's there in the moment and they say to someone, hey, we've got the vaccine, do you want it? People say, okay, yeah, I'll do it. I'm ready. But if there's this period of buildup and waiting and sometimes anxiety about it, people might not take the step to schedule it. They might not take the step to do it. So all of the work that the county and that the partners in federally qualified health centers like Alma Illery and PCHS centers, what they're doing is saying, we want to lower all of the barriers for you to come in and to get your vaccine. We want to consult with you as a partner, not tell you what you need to do, but listen to your concerns, validate those concerns, recognize they are based on historical failures and harm that have been perpetuated by these systems, and let you have agency in this process and let you listen to people who you trust. So I think, Ivan and Dr. Gloucester, what they're saying is the spirit of what our new Office of Community Health and Safety believes in, and certainly what the program that you, Reverend Burgess and Councilman Lavelle are advocating for, which is let's put the power back with the neighbors. So we stipend neighbors, community members to take these trainings through community-based organizations, and then we support them in going out to their peers, their community members, their friends, and having real conversations, not forcing or coercing, but allowing people to talk and think through it. And then we really hope to make that vaccine available as quickly as possible. So there's not time to go back and sort of resume a sense of anxiety, but really to feel supported and secure in that decision they've made.
And by the way, as you know, Laura, this is one, not the only, but this is many of the first endeavors of taking money that was originally earmarked for public safety and investing that money into preventative social services. And so Councilman Lavelle and I and council, we led council and the mayor agreed to move dollars away from public safety and police money to actually now invest in social services. Dr. Gloucester, for a long time, I was on Tobacco Free Allegheny, right? I was on the board of trying to get people, and particularly Black people, to stop smoking. But I guess I want to ask you, what are the major problems that African Americans have to their health? What are the major risk factors? What are those health disparities? What are the major things that you see in the Black community that is killing Black people, unfortunately, at younger ages?
Well, I think we hear about them daily as it pertains to diabetes, hypertension, asthma, obesity, and then our lifestyle, if you will, at times in dealing with the issues that we do deal with racism and other things that we medicate with improper food and improper diet, as well as those things like you mentioned, whether it's alcohol or tobacco as well, to try to deal with life, if you will. So and I think when you put all that with, now put on top of that the stress of racism and the other issues that we're dealing with, those are contributing to the health disparities. And also, when we look at a path forward to help improve things, we've already gone into the issue with a lack of trust within the medical system and those things. So these are creating barriers to path forward or getting out of those things. But I think we are making strides forward from the standpoint of looking at these issues from a holistic perspective. So the fact that looking at trying to address all the social determinants of health as we focus on, physical health, mental health, and then those other factors that can contribute, whether it's environment or jobs and those other things, that if we're working in a concerted effort with other community partners to address the person as a whole, I think that's our path forward to really improving things.
So talk to me a little bit, and this is probably a joint question, I guess, anyone can respond, but I'm particularly interested to hear from Mr. Juzang. How does this play itself out in the long run, right? So we're engaging this campaign now because of COVID, but to Dr. Glosser's point, we have all these underlying issues that COVID has simply exacerbated. How does this campaign translate a year from now into our community becoming a healthier community? Is there a way for this campaign to, once someone's been educated around the vaccination, can they also then become educated on all the issues Dr. Glosser just spoke about, the hypertension, the diabetes, all those other sort of issues?
Yeah, that's the long game. You hit it right on the head. So thinking about what Laura just described, and because we do these behavioral health campaigns, what we're saying is at that local level, it's not only the call, the conversation. This is how behavior change works. If you look at DiClemente's model of behavior change, you have to have this behavior change happens in a social context. There's argument, counter argument. You're able to get the cost benefits to change in your behavior. So that's the first thing that happens. So we actually get behavior change in terms of the community now knowing how to deal with and be safe around COVID. The second thing, though, you have to start thinking about is now we're putting these health communications and community engagement skills in the community. So now people have these skills that they're using for this particular content now, but now we can talk about youth violence. We can talk about substance abuse. We can talk about early childhood development. We can talk about, access to healthcare. So, we can put in different content, but you got to have the basic health communications and community engagement skills. So now we get those skills. And then what I always think is extremely important is then now that you have this relationship, how can we get folks to access services? What I always say is that it's not, people have been so mistreated by systems that you almost have to do a warm handoff. I say, don't refer folks to systems, do a warm handoff, walk them in so that then we can actually start helping people navigate systemic racism and we can do the advocacy associated with it. So now take that as I just said, at the micro level, now multiply that by 1,000 community leaders across the county. Now you get what I call the multiplier effect. So if you have these leaders and then they're working with their constituent, and if they're doing it right, then they're getting the word of mouth off of that conversation. You're talking about a reach that goes on much better than radio, much better than transit ads, much better than TV ads, because as Laura said, the sender of the message is trusted, and you have behavior change that happens in a social context. So this is really the reason why we were interested in this campaign. Obviously we want to address COVID, but how do we start talking about substance abuse, youth violence? How do we start talking about chronic diseases? How do we start making sure folks know about, I do research around the country. I mean, you guys are lucky to have a Dr. Gloucester, but folks don't know about community health centers and federally qualified health centers in their locations. How do we make that the end campaign? If we can get people connected to a community health center, do you know how big of a safety net that is? And then you have that relationship that can enable us to deal with a lot of health disparities. So great question, but that's the point. We have to do it. And by the way, there's a number of case studies that document the impact of community engagement. If you look at HIV right now is still primarily in Black communities and with men who have sex with men. That's where the HIV epidemic really still exists. If you look at what white gay men did 20 years ago, what did they do? They mobilized. They did what Laura said. They got grants. They got funds. They created nonprofits. They created healthcare agencies. You don't have that disparity there because they put the skills into the community. That's what this hopefully will be the starting process of, is starting to put those skills into the community.
Dr. Gloucester, I should have asked you this earlier, I'm sorry. If you would, although all of us are familiar, if you talk a little bit about primary care, maybe people don't understand what the primary care network is. I think if you sort of talk to us about what that is, and then talk a little bit about your need to have a new headquarters. I believe that one of the things I hope that we can do by emphasizing all the services and partnering is begin to create a community consensus around providing you with a world-class new health facility.
Thank you, Reverend Burgess, again. So yes, primary care health services, we are actually one of the first community health centers that federally qualified community health centers that started in the country back in the late 60s as the Homewood Neighborhood Health Center. And then we were incorporated as primary care health services in 1977. And our headquarters is the Alma Illery Medical Center that a lot of people know about. But we've grown over the years to 9 community health center sites throughout the county, where we're located in McKeesport, Braddock, Homestead, Hazelwood, the West End, the Hill District, East Liberty, and Wilkinsburg, as well as Homewood. And we exist as federally qualified health centers as entities that serve everyone. So we take you, if you have insurance, that's a misconception. Some people think we're just there for free care or for those who don't have insurance, but we take you if you do have insurance, as well as those who do not, or those who have any form of insurance. And we see you without regard for your ability to pay. We have what's called a sliding fee schedule for those who don't have insurance. Having said that, when we do the fee schedule based on your income or lack thereof, and it says, okay, your services today, instead of costing $200, costs $20, and you say, well, I don't have $20, we say, okay, well then we're still going to see you. That's our mission. And I started working at primary care initially 26 years ago, 1995, came to Homewood in Alma Illery, and I was there for 16 years and 7 years over on the north side with Northside Christian Health Center, and came back as the CEO of primary care in 2018. And I said all that to say that my passion, as well as our doctors and nurses and nurse practitioners and PAs, are just for our communities, for those who are the underserved, those that, other practices don't want because the revenue isn't satisfactory. But our federally qualified health centers are comprehensive as well. So as I mentioned, we see from birth through geriatrics or the elderly for primary care. We have podiatry care. We have women's health. We have actually our own in-house pharmacy, which a lot of people don't realize at Alma Illery, which is able to deliver medications to our other sites as well. We have behavioral health care where we have behavioral health therapists, social workers. We also have our own laboratory, level 3 laboratory. Primary care health services as well operates the Wilkinsburg Family Support Center, as well as we deliver homeless health care throughout the county through 4 direct care sites in the county, as well as we fund some indirect care at some additional sites. So we're the largest FQHC in the county. And again, we're here for everyone, and especially those of need and for those who are experiencing health disparities.
And Dr. Lush, what you mentioned behavioral health, and I want to stay there for just a minute. We've had other shows talking about just stress that Black people are under, and that COVID, in many ways, we've solved that, exacerbate the trauma and the stress in Black communities. So I want to talk a little deviate from that. How do we desensitize take the stigma away, the stigmatized mental health issues? How do we get, as a pastor, sometimes I'll get people who want counseling, but really they would be better served, rather than my sort of pastoral counseling is sort of, although helpful, is short term. Many of them, I think, need to be in a longer term behavioral health setting. How do we do that? How do we make behavioral health more accessible to Black people in the Black community?
Well, I think one of the ways is through federally qualified health centers, and that we integrate it to our care, so that if you come in for a medical visit, our providers are asking some questions about how you're doing, whether you felt down in the past few days, whether you're stressed, whether you're having issues with obtaining food and other issues. And should those individuals, again, share those issues, we can make, as Ivan mentioned, in this regard, especially the warm handoff right within our organization to those behavioral health therapists. And not only just from the standpoint of within the organization, we're working to integrate it physically, so that it's not like you go to, you have to leave the medical unit to then go to some other floor and see the psychiatrist or the behavioral health therapist. That individual would be right there on the unit and able to see you right where you're getting your medical care. And so to get people to really see it even physically as this is a part of your whole health. This isn't some stigmatized thing that people don't talk about, and we keep it separate and then keep that narrative going that it's taboo or something. But no, we talk about whole person care, and we really encourage everyone to access it, and like I said, we're breaking down those barriers to access to behavioral health.
Can I respond to that real quick? Just real quick. Just understand that, as we talk about, mistreatment, particularly in Black communities, mental health is a major source of that. Most people have traditionally used mental health services because they've been mandated or forced to use it. So I think mental health needs a total reframing. And I think, if you look again at suburban educated communities, there's this whole notion of self-care, and it's just framed so differently, so positively. And in our communities, it's really framed as a deficit, that there's something wrong with you, that you're crazy. I think it needs a reframing, a rebranding, because if you talk to some of the top Black psychiatrists, particularly Dr. Carl Bell out of Chicago, who's now passed, one of the things he'd say is that, Black people came out of slavery, so they had resiliency, they had mental wellness, they had things that we're not lifting up. We only focus on their deficits. We have to focus on some of the positive things. He would always say, Black people have mental wellness because, they've been the coolest in some of the stickiest situations. He says, when you're cool in a sticky situation, that's wellness. He says, but it's just we've been demonized, and it's been used differently for us, more as a punitive institution versus a wellness institution. So I think, this is why you have to have it in places like Dr. Gloucester, so that people can see folks that look like them, that have their best interests at hand, that are going to treat them right. It needs a rebranding, and folks need to actually be able to experience a new set of mental health services, not the traditional ones that have been that the Black community has been exposed to traditionally.
Say more about that branding before you, because you do this. This is what you do. So how what would that look like? I mean, is that something that this present campaign could morph into? Talk to me more about how we do that.
Well, actually, we do have messaging in this campaign around how COVID has been one of those stressors. So like we use terms like, how do we deal with stress? How do we deal with trauma? We use the language that's in our communities, but at the same time, we also talk about protective factors or resiliency, and the fact that you can get through the other side. You have self-efficacy. You have the confidence and skills to do this. You've done it. Your family has done it for years. So we take a strength-based approach to how we're even talking to the community versus saying there's something wrong with you. No, we're saying, no, there are assets there. If you're here today, you had to get here. You had some agency that enabled you to. So we always try to lift people up in our conversations. I think wellness is something we have to do, particularly if you look at youth violence. This is a mental, it's obviously a public health issue in terms of epidemiology, but it's really a mental health issue. I'm coping with stress and trauma, and I'm coping with it by acting out in violence versus looking and understanding that there's positive ways and alternate ways to deal with the stress and trauma. So I absolutely think what we're trying to do here as we mobilize communities is then to start having those conversations around community trauma that exists and start saying, how do we get upstream? How do we start understanding what we need to do to promote more wellness so that people can cope with stress and trauma differently?
And if I could add to, what are the barriers that people face in accessing resources, support, and care? Ivan, you said something which reminded me of what an activist in Philly said, which was, people aren't service resistant, services are people resistant. And this gets back to the idea of how do we support people and getting the resources, the care, and everything they need in their own communities. That doesn't mean always, but to the degree that it doesn't require 3 bus transfers to get a basic primary health screening. Why should someone have to? I know Pittsburghers, the riff is that they don't like crossing bridges, but when it's something really basic that you need, why does it have to become a day-long endeavor to get something that's so basic? The other piece of this is, if we can do what Ivan and Dr. Gloucester is saying, which is promoting agency among people, they'll tell us what they need. When you talk to people who you say, oh, I'd really like to help you with your substance use or your mental health, they might say, my utilities are shut off. I'm living in a home where I'm exposed to domestic violence, and I'm just trying to survive. Well, let's listen to you and say you need a safe home. You don't, like, your substance use is something that's allowing you to cope with the reality of what you're experiencing. So that ability to listen to people, which is what primary care physicians can do and what community members can do, restores the agency of a person to say, I know this is the symptom. I know this is what you see on the surface, but the reality, the root cause of what's going on and what I'm experiencing is going to require a little more time, a little more digging. But if we can get to that, then other issues that are downstream get addressed. And, again, we can even apply that to like public safety. If we get upstream, and I know you all declared racism as a public health issue. If we address racism as a public health issue, we don't need to address racism as it manifests in unsafe situations for people.
Okay, so here's my question. How do we track the success of this current campaign, this current process, so that we can then build it out into all these other avenues that you are saying this approach can assist us with, whether it's the crime, mental health? How do we track the success of this so that we can replicate it to address other issues?
So let me tell you how we're doing. Remember, I mentioned the organizational survey. We call it a reach and impact survey. So as each person registers and they complete the survey, then in a sense, we can ultimately aggregate what people are telling us their reach and impact is. what zip code there. We'll also be able to do GIS mapping, exactly where they're at in the county. So the notion is we want to be able to create this community network, this channel, so that we know where our trained community leaders are, how many people they say they have access to, what's the multiplier effect on top of that. Do they have access to, like, a church where they may be able to hold a vaccination pop-up or a mobile van? So we'll have all of that information. Then they go through the training, and then as they do the training, we actually measure their user engagement with the portal. So we know if they downloaded the digital toolkit, if they watched the videos, if they shared the videos. So then we can do the analytics to see the kind of impact it has from there. But the key thing for me at the end of the day that I think you guys should be interested is to say, how many people have been trained in good health, we call it trauma-informed health communications? How many people have been trained in community engagement strategies that counter lack of trust? And then we can start having a number of conversations around different topics. You should ask me and Dr. Gloucester at the end of this, how many people have been trained, how many people have stayed engaged, and how many people have said, because we're going to ask them this, how many people are going to tell us that they want to stay involved in the project post the COVID resources for this campaign. And that's what we're here for. We're here for the long haul. So whether the county or whoever funds it, we will continue to build out the network, because we have got to start focusing on agency to deal with health disparities in our community.
I would add that I think that we can also track it, although this is further down the road, but I think that you can track those individuals within our agencies that have been touched and become users, again, of the FQHCs and other agencies through this process, to see, again, look at how many warm handoffs did occur, how was access improved to services, and then ultimately outcomes improved. And I know that's a longer thing down the line, but to be able to look at those individuals as you track them through our process.
But I agree with that last one. We should make one of the last activities funded by the county to say, let's get folks connected to their local community health center, and then let's actually track the number of people that get those warm handoffs, because that's big. If you get folks to re-engage with healthcare, then we can start talking to them about a variety of their comorbidities, particularly as we want to deal with underlying health conditions. I mean, I think that's critical, because if they're not connected to healthcare, there's not a lot we can do. We can do prevention, but a lot of these folks need intervention, need treatment, and this is the only way we're going to do it is we connect them directly to, to culturally relevant services that like Dr. Gloucester provides.
And what their experiences are in healthcare, to make sure that after you've made that warm handoff, that the experience they're having, remains supportive. Because I think that the work that Ivan and Dr. Gloucester and others do to make that handoff can be undermined by an experience that doesn't meet the needs or reflect the values of the people who are seeking that care. And the other thing, the work that Ivan and Dr. Gloucester and you all are doing is creating a network of people who will be responsive and say, well, okay, so COVID, we're working toward making that not a topic, but then what, right? Then it gets down into all of the things that we've identified and many people have identified as other issues, and how do we start to how do we continue to support the people who are going to prioritize resource, connections and warm handoffs for people?
So tell me, Laura, how can long term, how do you see your office, and your office is fairly new, long term, how do you see the city participating in this endeavor? How can we continue this momentum? What's your thinking? You think about this stuff every day. So how do we do? What are the things we need to do, you think?
I think we see partners in the community who are already working toward this, and rather than reinventing the wheel, which is what we're not going to do here. We're going to work with existing resources and campaigns and support. But when we see community health advocates, community health workers, neighborhood health deputies, we can start, and even the frankly incredible work of GVI. Those are people who know neighbors and know people far better than people that don't get to interact with the community on a daily basis. So what are the ways that we continue to elevate them as a network of resource providers, of supporters, and ultimately as connectors, who can be in a position to tell us when stuff isn't working? I mean, I think that probably one of the most significant challenges I've witnessed is that we work to create a program, we're excited about it, we do it, we don't have an iterative process to say, oops, this isn't working, oops, we didn't get this right. And that by the end, we all realize where we could have done differently or done better. But when you have a whole series of people who live and work in the community who can tell you that, we can iterate faster, we can work faster. So I could envision a scenario, and it doesn't have to be something that's a whole series of government deputies, but a community-based organizations, much like GVI does, where we have people in our communities who are our ambassadors. They're our leaders. They're the people that we recognize are actually taking the burden off of the public safety infrastructure and off of the systems infrastructure, but more importantly, precluding the trauma of systems involvement and the recurrent trauma. Because once someone is involved in a system, it's very difficult to sort of extricate them and connect them to something that's more community-based. You have prescriptive processes where you have to be involved with a particular provider on a particular day, and let's stop that. So I think part of it is re-empowering community members to be our advocates, our leaders, our deputies in the community, whether they are formally part of the government or not. And the second piece is when we have public safety engagements, because truly that's our biggest reach in the community at this moment. It's over half the government. When one happens, what are the ways if a medic or a firefighter goes into a home and sees underlying issues, social determinants of health that are affecting a person's ability to thrive? What are the ways that we follow up with that person and connect them with services? How do they get connected with PCHS? How do they get connected with other providers that might be able to mitigate those issues, so we don't have continued recurrent point-based engagements, but rather a really meaningful relationships with something like a group like an FQHC, or with a mental and behavioral health provider who's going to be able to meet those needs. Or, as Ivan was saying, food, right? How do we get people connected with food or safe housing? So I think we also are looking at how do we optimize the engagements that we do have on a public safety infrastructure to bring in partners that can have durable relationships. And that's good for everybody. That's good for our community. It's good for our first responders, and it's good for city residents, because we know that we're more meaningfully supporting and helping people.
So that's a great point, if you don't mind me adding to that. The benefits of mobilizing communities are we forget that by doing community mobilization, you're actually creating village. Village is social connectedness. Social connectedness is a mental wellness. So you're actually putting in mental wellness because you're creating more social fabric. You're creating connectedness. Just doing that is going to lift all boats in the lake. But to Laura's other point, you guys, when you do good community engagement and you now have these advocates, you can also do better data gathering. You don't have to get it from your traditional institutional sources. We have a network of almost 1,500 community-based organizations across the state of Louisiana. We're doing work across the state for the health department. When we do work, I don't try to go through institutions, NGOs and institutions that have mistreated. I go through these gatekeepers. I go through the community-based organizations, and I'm able to get much richer survey data, focus group data, insights, because it's coming from the community itself. So remember, when I talked about the channel to put information into the community, it's also a channel to bring information out of the community. That's going to give you the best qualitative and quantitative data to make good decisions. So that's how you're literally building capacity for us to do stuff that create wellness in and of itself.
We've got a little bit of time left. Micah Smith has been monitoring questions, so I want to bring her on. But as she comes on, Dr. Gloucester, can you tell us what you're aware or knowledgeable of as it relates to the vaccine in children? And the reason why I'm asking, and this is somewhat even personal, many families are starting to finally send their children back to school. Mine started 2 weeks ago. They go twice a week. But I had, during this entire time, never knew a kid that had actually been diagnosed. My son plays baseball, and it was actually a child on his team that was diagnosed with COVID 2 weeks ago. So we had to shut it down, make sure every kid got tested, didn't play for 2 weeks. So I'm just curious, can you share any information you have with us as it relates to children eventually becoming vaccinated?
Sure. I am thankful that some school districts are embarking on a plan to provide mass vaccination, as well as, we at Primary Care Health Services, all of our sites, we're working through a process now to identify those families that have not been vaccinated yet. And throughout the summer, reach out to them, not wait for them to reach out to us to try to facilitate vaccination for those kids. As many of you know, Pfizer vaccine has received emergency use authorization down to the age of 12. And the great news is it's showing to be 100% effective at preventing the infection. So that's great news as well. Also, kids tend to do great with vaccines. Even the concerns around the vaccine in our older adult population and our adult population with side effects, that kids tend to not have that, as well as not nearly as significant if they're going to have a reaction. And they also mount an incredibly good immune response, and that's why the vaccine's been shown to be so effective. So I think that what I'm trying to tell parents to do is contact your pediatrician, your family doctors now, and if your school hasn't reached out and you're not aware of other mass efforts, please, by all means, contact your physician. If you don't know of one that has the vaccine, we welcome you at Primary Care Health Services, as well as the other federally qualified health centers that we would love to, the opportunity to serve you and get your child the vaccine.
Thank you. Micah?
Yes, thank you. The first question I believe would be directed to Dr. Gloucester, which is just generally where can we get the COVID vaccine at the moment in Pittsburgh?
So again, the great news is beyond us as fairly qualified health centers that I've mentioned. We know of many mass vaccine sites, whether they are in the Hill District or downtown, but moving away from those, we've actually partnered with some community organizations, for instance, down in Hazelwood. Besides our Hazelwood Community Health Center, the Spartan Center, we're doing vaccines on Fridays at the Spartan Center in May. We're doing vaccines at Hosanna House in Wilkinsburg on Tuesdays, this month in May, as well as moving into June. And at all of our sites as well, you can call to get a vaccine. But thankfully now there's plenty of supply and lots of vaccine distribution sites that you can access. But again, welcome you calling us, and given our network and the other FQHCs, we'd be happy to get people a vaccine.
Thank you. The second question was, how does the holistic public health approach differ from the historical approach to health in Black communities? And I think that's open.
Well, I think this approach that we're using is what we call community-centered. It's buy-in for the community. Traditional public health has really been what we call, we identify what the message is that we want to get across. It's more based in science and literature, and then we kind of use whatever channels we think we want to use to get the message to the consumer. That hasn't worked as well because it's sometimes not culturally relevant. And matter of fact, sometimes it actually backfires and is insulting. So if you start with the community and you take a community-centered approach and understand, one, how they view the world, secondly, what's their communications culture, then you can make sure you're crafting your message to their worldview. But all of our messages, the number one thing we say is that if you don't talk to their worldview, they'll opt out of your message. They'll say, you're not talking to how I view the world. So it's critical to be able to take a community-centered approach, and by mobilizing and training community leaders who know their communities, they're even closer to being able to make sure that they're speaking to the worldview of that audience. So it's really just more of a what we call an oral-based approach to a literate-based approach. Public health has usually been literate-based, and what we're saying is that you have to be oral-based because we come from the oral tradition. We come from the narrative, from the storytelling. And so how do we speak to our communities and still provide the same science, but do it in a way that speaks to their communications culture?
Thank you.
Thank you.
And before we wrap up, will you please provide the website once again, Mr. Juzang?
Truthnotcovid.org. We want the truth, not covid.org. So truthnotcovid.org.
Dr. Gloucester, why don't you give your phone number, the main number for people to call if they want COVID or if they want to, get some primary care services.
Absolutely. So our headquarters at Alma Hillary, the telephone number, main number is 412-244-4700. That's 412-244-4700.
Thank you. Well, that is all the time we have for today's show. We want to thank our guests, Laura Dragowski, Critical Communities Manager for the City of Pittsburgh, Dr. Jerome Gloucester, and Ivan Juzang, founder and president of Mead Productions. In order to have a significant investment in the Black community, it is imperative that we make our community safe and peaceful, and we are all committed to rebuilding our Black communities in Pittsburgh for Black people by Black people with our partners and allies. And obviously, we also want to encourage everyone, if they have not done so thus far, to please get vaccinated.
The whole purpose of our leadership and of this media show is to help to facilitate all the things that will uplift Black people. Councilman Lavelle and I sit and counsel, and our job is to lift up all of those issues, whether in education, health, public safety, economic development, public housing, affordable housing, all of those things. That's what this show is to do, is that we know that not one thing was going to make the Black community better, but all these things together at scale, we believe will empower the Black community. I want to thank all of you for watching and participating in this town hall meeting. Remember, you can watch this show on Facebook, the city's YouTube channel, or the city's cable channel. A new meeting occurs every Wednesday. By working together, united in purpose, we can transform our city, strengthen it for all of its residents. Pittsburgh is becoming a city for all by becoming a city where Black Pittsburgh matters. Good evening, stay safe, and be blessed.